Coming up on the program, our healthcare experts discuss the latest in medical news from the previous month, and then they answer your questions.
Support for What's Health Got to Do with It is provided in part by the American Brain Foundation invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at americanbrainfoundation.org. Rethreaded knows human trafficking destroys lives, but they also know it's not the end of the story. Rethreaded believes in the potential and power of all survivors to reclaim their lives. Visit rethreaded.com to learn more. And Elevate Med. Through mentorship, leadership development, financial literacy, a robust peer network, and tuition-based scholarship support, Elevate Med is dedicated to the next generation of diverse physician leaders as a tangible step towards the eradication of health disparities. More at elevatemed.org.
Hi, I'm Dr. Joe Sirven, a practicing neurologist at Mayo Clinic, professor of healthcare administration and policy at Arizona State University. This is What's Health Got to Do with It, which looks at where and how healthcare intersects with your life, helping you get the medical answers you want. Coming up, it's our monthly medical roundtable, and we're diving into the headlines you couldn't miss, like preventable diseases making an alarming comeback, dogs trained to sniff out Parkinson's, a game-changing menstrual pad detecting illness, and Ozempic's surprising promise for brain health. Plus, a deadly twist on gonorrhea and the real deal with hydration powders. Then, our experts tackle your burning questions and break down what these stories mean for you. But first, as usual, July delivered a whirlwind of health news. Some breakthroughs, some warnings, all sparking big conversations. From old diseases reemerging to high-tech tools and surprising health discoveries, let's unpack what's shaping the future of your health. Talking to us today about these topics are Dr. Tina Arden. She is a practicing family physician, primary care doctor at Mayo Clinic in Jacksonville, Florida. Dr. Arden, welcome as always.
Thank you so much for having me back.
It's great to have you here. And Chad Nielsen, he is Director of Infection Control and Prevention and epidemiologist at the Nemours Children's Center in Orlando. Chad, always good to have you here.
Thanks for having me, Joe.
Last but certainly not least, he's new to our roundtable, Dr. Jose Posas. He is a practicing neurologist at the University of Virginia in Charlottesville. Dr. Posas, welcome to our show.
Dr. Sirven, it's such a pleasure to be here. Thank you for having me.
You bet. It's so excited to have you all here. And we're going to get right into it. Our first topic is measles, rubella, and polio. Is this the sign of the return of preventable diseases? And Chad, I'm going to point this one at you. With outbreaks of previously eradicated measles leading the news for months, we've covered it on this show for many, many episodes. More epidemics may be in store. As the USA's vaccination rates among kids continue to plummet, concerns are rising over the potential for infectious diseases to spread rapidly in the coming years and decades. Research published in the medical journal JAMA suggests a continued decline could lead to millions of infections from diseases currently considered under control or eradicated. This JAMA study found that of 2,237 counties across the U.S., 78% reported declines in vaccination rates for measles, mumps, and rubella from 2019 through 2024. The study said that measles is likely to return to endemic levels if MMR vaccine rates, that's measles, rubella, and mumps, continue to decline. So, Chad, the JAMA studies is giving us a big warning. It says that these conditions could return to endemic levels in the U.S. I guess let's start with just definitions. You're an epidemiologist. What does endemic mean for communities? And then my quick follow-up, how worried should we all be about seeing large measles and other conditions outbreaks occurring again?
Yeah, so in epidemiology, when we say the term endemic, what we mean is a disease is commonly present in the population with a stable number of cases over time and also with somewhat of a predictable pattern. So think of influenza, the flu, or rhinovirus. Those tend to be endemic. They don't ever really go away. We know when they come and go based on seasonality and whatnot. Versus a pandemic, which think about COVID, which is it affects everyone and sort of it's new and unpredictable. So I certainly think the next few years will really determine if measles here in the United States will become endemic. But given falling vaccination rates, eroding public health policies, and just frankly, what I've talked about before on the show, misinformation is everywhere. I think the ingredients are all there for measles, mumps, rubella, pertussis, all of these things to become endemic again. I think if we're going to avoid it becoming endemic, we need a lot of work to happen very quickly.
Let me latch on to one of the points you made. The biggest finding in the study, arguably, was that these vaccine rates is falling in 78%. That's more than 3/4 of U.S. counties. We're not even talking states, counties. We've talked about this before, but talk to us again. What is leading to this decline? Is it one thing? Is it multiple things? What's the biggest driver here?
Yeah, I think it's multiple things, in my opinion, that I think are driving these rates. And first of which is policy changes amongst state or local governments across the country. What we're seeing across the United States in many states is weakening guidance and mandates on vaccinations among school-aged kids. And so as the government starts allowing, and I say government is a broad term, state, local, or federal, as the government starts allowing more and more kids to opt out, waiver out, or exemption out of vaccines, you're going to have a more vulnerable population. And so I think part of what's happening to sort of fuel that is there's just so much misinformation out there, and the discourse of public health sort of not knowing what they're doing or going back and forth about big decisions, much like we might have experienced during the COVID pandemic, are all fueling this to parents to say, hey, if the state or the county is giving me an option out of this, yeah, I'm going to take that option. And so you've just got so much misinformation out there that parents don't know what to do. So they're taking that exit door that the government is allowing them to take. And so I think there's a lot of things that we need to do to fix that. Number one, combat misinformation that's everywhere. Number two, we really do need to re-strengthen some of our vaccine policies for school-age kids. And until we do that, we're going to continue to see more of these cases.
Chad, if measles and, God forbid, polio makes a comeback, what could that look like in a practical sense for all of us, the listeners, for you, our panel? What would that look like in general?
I certainly think if we continue down the current path of seeing some of these things become endemic again, ultimately it's going to mean greater suffering for people and more specifically children. There's no other way to put that. If these preventable infections become commonplace again, you will see hospitals more stricken with sick kids. You're going to see emptier schools because kids are not in them because they're sick, which means you're going to have learning losses. And then, unfortunately, you're going to see families suffer the loss of their children, which, terribly has already happened to 2 unvaccinated kids in Texas who died of measles. As a parent myself, it really breaks my heart every time my daughter is sick, even just with the common cold, right? And I know anybody who's a parent will feel that same way. You hate seeing your kid sick, and you would take it on yourself if you could. But I do trust that medical science has fixes for this or prevention strategies, and that's vaccines. Vaccines to this day continue to be the single most important tool we have to prevent infections like measles, pertussis, polio, and more. So I really want to underline that fact that we know vaccines are safe, they're effective. We just really need the public to trust your medical providers and your public health officials so we can turn this around.
Well, I will hope most people will take your advice, especially as we get close to back to school season. We're going to switch to a very different topic. And this was a headline that caught many of our attention. And we'll just simply put it, can you smell Parkinson's disease? Two early studies suggested that sebum, this is an oily substance that protects your skin from drying out, may help identify Parkinson's disease. Two dogs, a golden retriever and a Labrador retriever, trained to distinguish sebum swabs from people with and without Parkinson's disease, demonstrated sensitivity of up to 80% and specificity of up to 98%, reported Nicola Rooney of the University of Bristol in England and colleagues in the Journal of Parkinson's Disease, where the study was published. Now, clearly, more research is needed, but the study suggests that perhaps a skin swab or smell test could be used to detect the disease. The dogs were tested using samples from 60 controls, that's people who did not have the condition, and 40 people who did have the condition and were not on medications. Dr. Posas, we're going to start with you here. These studies suggest that a simple skin swab or even a smell test could somehow, someday, help detect Parkinson's disease. How realistic is this?
Well, I think that it can be very realistic, right? So part of the thing with Parkinson's disease is that any movement disorder neurologist that you speak to today, or most of them, let's say, would say that Parkinson's disease is a clinical diagnosis. And you're absolutely right. This is something that could be a major breakthrough, but the tricky thing ends up being understanding the molecular or the microscopic level issue that's changing. Like, why are these dogs able to detect these things? So this all hinges on something called alpha-synuclein, which is a misfolded protein that occurs in Parkinson's that accumulates in different body tissues. Number one location for neurons in the body is your brain. Number two is your gut. Number three is your skin. So if it's misfolding within the skin, changing the way that the sebum is produced, that changes the volatile organic compounds that are produced when the sebum is created by your skin and your glands in your skin. And so, yes, therefore, you can have humans who have a genetic gift to be able to smell, but really these cute dogs, right? Bumper, the golden retriever, and Peanut, a black Labrador,
I love
being
it.
able to smell this stuff and detect it. And if you can train them to accurately sort of indicate, yes, this is there, this could be a game changer, but obviously there's lots of paths to complexity here. So think work in progress, but I think eventually if we can get a more reliable technology that finds these volatile organic compounds, could this be something that we roll out all over the world? You know, who knows? The imagination is the limit here, and it's exciting in the world of neurology to think about this.
I agree with you. Let me ask kind of a larger philosophical question. If we got to a place where Parkinson's could be detected very early, with something like smell or skin test of some sort, would that make a big difference for patients? Could you talk about that? What does early detection get you for a condition like Parkinson's?
I think early detection gets us peace of mind and quality of life in current state. You know, if I was to snap my fingers or find a genie and wish that Parkinson's could be detected early, there would be people, and we know that, Dr. Sirven, you and I know from our neurology training, and our colleagues know that Parkinson's can have motor symptoms, and that's usually the last type of symptom they get. They typically, up to a decade before, and in some cases a little earlier, get non-motor symptoms, including things like REM behavior disorder, where they're acting out their dreams and punching whoever's in the bed with them when they're fighting a dragon or something in the nightmare. They have problems with digestion and they lose sense of smell, not related to COVID, but because the neurons within the olfactory bulb start malfunctioning because of the alpha-synuclein buildup. So figuring this out now gives us an on-ramp for people who have non-motor Parkinson's symptoms to start working on the things that we know help in terms of reducing inflammation of the brain and improving brain health in general, diet, exercise, et cetera, et cetera, et cetera. But I think in the future, if we can find and detect these people earlier, could we intervene earlier and stop that alpha-synuclein from folding? In other words, giving someone, instead of 10 years before they go from non-motor to motor symptoms of Parkinson's, 20 or 30 or 40 years, or sort of delay it inevitably, if we can reduce the alpha-synuclein misfolding, I mean, that's the dream, right? Stop people from ever progressing to the terrible shakes and tics and falls and stiffness and the visible signs of Parkinson's. So arrested at the invisible phase, which I think is tremendous.
As our last piece, and I wanted to take this based on the answer to our first question with you. you mentioned that Parkinson's affects three areas, and maybe I'll ask that. When we see something like this, a headline with these couple of dogs that you mentioned by name, I loved it. Do you see like something like smell-based technology or skin sampling occurring as a diagnostic test all over the country?
Yes, I mean, I think that part of the reason I love what I do, and part of the reason I love the pushing the scientific envelope, not me myself personally, but watching the scientific community do these amazing things, is being able to push the boundaries of what we know, right? We as human beings, we have limits, but if we can aid ourselves with animal input or thermal mass spec gas chromatography technologies at the clinic or point of care, I think this could really be life-changing and altering major quality of life and helping alleviate suffering and helping alleviate people who have questions about, well, it's in my family. I had a grandma and an aunt, and what else do we do? I think this will really help large swaths of people who have this as a question that need some answers and really some compassion.
I love it, and we'll remain hopeful with all of this. We're going to pivot to yet another topic. One of the headlines that emerged out of this past month was a new technological device, which was a revolutionary smart pad that could literally transform women's health. The idea was using the concept of menstrual blood to let it serve as a diagnostic test using this pad that could detect certain conditions. This is not sci-fi in many ways. I thought we should have probably thought of this many years earlier, but what a cool thing that could occur in terms of a way of helping women's health. Dr. Arden, I'm going to point this at you. How significant is this development for early disease detection for conditions like ovarian cancer or maybe endometriosis that are often diagnosed late in women, utilizing this type of technology?
Yeah, thank you. This idea of this type of technology, I think, is incredibly significant. We know both ovarian cancer and endometriosis are difficult diagnoses to make for a number of reasons. Although it's rare, ovarian cancer is the sixth leading cause of cancer in women and also the leading cause of death from cancer of the reproductive system. And unfortunately, we just have not been able to find tests that can reliably identify this before patients are often symptomatic. And once symptoms appear, the cancer typically is quite advanced and more difficult to treat. On the other hand, endometriosis is another condition that really affects a lot of women, about 10% of women, and it is a very painful condition where tissue that lines the uterus grows outside of that uterus. It's responsive to hormones, so often women have very painful menstrual cycles, so it can be a detriment to their quality of life for many years. It's often a difficult and delayed diagnosis to make as well. And so estimates are anywhere from 4 to 11 years for us to make an appropriate and accurate diagnosis of endometriosis and help these women. So a test that can help us identify these two diseases earlier is really exciting to think about.
When we get into the specifics of a technology like this, and I'm wondering if you can comment on this, what are the potential benefits as well as the limitations of using something like menstrual blood versus just simply a traditional blood draw for health monitoring? How do you see this potential technology impacting healthcare access and maybe in areas that aren't underserved? But talk about the benefits and the limitations first.
Yeah, I think it definitely has a lot of potential advantages. It's a really interesting idea to use something that's already readily available to a woman, her menstrual blood, that's accessible and easy to do in the comfort of your home. Whereas other tests involve a patient's time, they involve potential travel to a lab or to the doctor's office, and oftentimes discomfort that can come with venous draws. A lot of patients that have needle phobia and often avoid needle draws for that reason too, right? So something that is not painful is really a great selling point. But as you mentioned, this is a point of care device that does rely on technology. So a smartphone, the use of an app, access to Wi-Fi and internet and those sorts of things for all this to work well. And I think it can be easy in 2025 to assume that everyone has easy and reliable and consistent access to this technology, but that is not the case. Many patients don't, and many communities may have very limited, if any, access to this technology. So as exciting as these things are when it comes to how I think about community health as a primary care physician, we do always want to be thoughtful about making sure we can close those gaps in care so that patients aren't disadvantaged to having access to life-saving care just because of where they grow up and their access to technology.
As a family physician, what would you want patients to understand about this technology, both its promise and its role as a screening tool, rather than, this is a replacement for going, what's out there now to make these diagnoses or to perhaps see someone like yourself?
Yeah, excellent question. So it's probably helpful for your listeners to understand what we mean by screening. So a screening test or screening is really an effort to look for cancer before someone has symptoms. The hope is that then we can intervene earlier, perhaps on something that's just very, early at stage, mildly abnormal, and even prevent cancers from developing. So a great example of a cancer screening tool that we have available now is for colon cancer screening, and that is colonoscopy. So we can find cancers early, remove precancerous polyps, and even prevent development of colon cancer. And so thinking about that, we're thinking about a test that hopefully will identify a problem earlier before someone is symptomatic, but any test also has risk and benefits, and we need to make sure we are having those conversations with our patients. There's the idea of a false positive. So where a screening test or some type of diagnostic test is abnormal or says it's positive, but the patient does not actually have the disease. And a false positive really can lead to significant harms to a patient, especially when you're talking about something like cancer. You imagine a patient gets an abnormal result with this technology. Now they have a lot of anxiety and worry about what could be a potentially devastating cancer diagnosis. And then we need to follow up with additional testing to confirm. And sometimes these tests can have their own risk and benefits. They might be more invasive. Maybe the extreme example would be leading to some type of surgery for a concern for ovarian cancer that wasn't necessary. And we know surgery is a high risk activity in and of itself. So I think it's really important when these things come out that patients have a good discussion with their physician about how accurate these tests can be, what are the risks and benefits, and just understand what road you may go down with these test results.
And to all of our listeners out there, you are listening to What's Health Got to Do with It on WJCT News 89.9. I'm Dr. Joe Sirven. If you're just joining us, it's our monthly medical roundtable, and we want to hear from you. Tag me on social media at JServin. Hey, it's Dr. Joe Sirven. I have a new show called This Week in Health, and it's part of WJCT News Now. Local news you can listen to anytime, anywhere. When you sign up, you'll unlock 4 local podcasts delivered straight to your podcast app. I break down the week's biggest health headlines and what they mean for you. Start a free 30-day trial at wjct.org/newsnow. And if you like it, become a monthly donor to support WJCT Public Media. We're going to switch to a very different topic, and one that we seem to kind of always find in our headlines, and that has something to do with either a Ozempic, Wegovy, or something similar to that. In this particular headline, a new study led by researchers at Case Western Reserve University in Cleveland suggests that semaglutide, this is the active ingredient in the diabetes and weight loss medications Ozempic and Wegovy, could lower the risk of developing vascular dementia, particularly among people with type 2 diabetes. The study was published in the Journal of Alzheimer's Disease, and they analyzed electronic health records from over 1.7 million adults in the United States with type 2 diabetes. Participants taking this drug had a significantly lower risk of developing vascular dementia compared to those taking other diabetes medications. Dr. Posas, I'm going to ask you to comment on this. Start us off first by tell our listeners what exactly is vascular dementia. What are we talking about there?
Yeah, so the long answer for vascular dementia, Dr. Sirven, is that these are small microvascular injuries, small little strokes. As we age, as our arteries harden, if we have stroke risk factors like high blood pressure, and diabetes, will have a higher propensity of having more and more small strokes that eventually coalesce and sort of cut the cords and connections within our brains, especially within the deeper white matter structures, and can cause dementia and memory loss. The shorter way that I say it to my friends and family who are non-medical is the aphorism, how does the beaver fell the mighty oak tree? The answer is one bite at a time. So vascular dementia ends up being this issue of small insults that occur years and years over time, and eventually the cognitive function is no longer there because the brain can't send the signals from one part to another.
I love the analogy. Uh, Dr. Peza, semaglutide is proving to improve more than a few conditions. I'll just ask this philosophically. Is this a super ingredient, kind of like an aspirin that takes care of all these other issues? I mean, what's making this so effective?
It is one of those things that it feels like, is this a super drug? And the answer is it's not a super drug. What it does is something that is pervasive in our daily lives. What it does is it mediates the flow of it's a GLP-1 agonist. And what it does is it changes the flow of glucose. And glucose, that ends up being the sort of super ingredient, because that hyperglycemia and pro-inflammatory state that we have if we eat foods that are too high in caloric content but too low in nutritional content, that leads to a pro-inflammatory state within the brain. We think that the microglia, which are the sort of wrap it up into one. It's the policemen, it's the janitors, it's the firemen of the nervous system. They get kicked into a state of attack if there's too much glucose. But if you can modulate that with a GLP-1 receptor modulator like semaglutide, can you get them to reduce the pro-inflammatory markers within our brain that help them do those jobs to break down the blood-brain barrier and other things like that, and go in an increase of anti-inflammatory markers that help repair and fix tissue within the brain. So in this way, we think it can be both neuroprotective and reducing inflammation of the brain and nervous tissue.
What do you think the research that we need to determine whether this drug can be an effective prevention strategy for dementia? What else is needed to show that in your opinion?
I'm going to say something a little bit controversial, right?
Okay.
And I think this has to be like the bigger thought, like the esoteric thought here is, we are hairless apes who walk upright, which is relatively new in evolution on this planet. We're meant to eat protein in a large quantity, maybe once a week, once a month, right? That's the hunter-gatherer way.
Right.
And we're now able to have high doses of fats, carbohydrates, protein 3 times a day. And if you believe Taco Bell, there's fourth meal as well. And so is this something that's kicking us into a pro-inflammatory state too often and then harming ourselves down the way? I think so. So what research is needed to determine whether semaglutide can be an effective prevention strategy for dementia? I kind of think we're there, but even if you look at the study authors, they say that there are a lot of other factors that can lead to vascular dementia. And some of the treatments for that end up being diet, exercise, regular levels of sleep, hydration, things that are so boring for us doctors to say to patients, but are also so true in terms of improving quality of life and brain health.
I love it, and you've gotten me hungry for Taco Bell when you mentioned that. So I'm going to go to the next topic. And boy, are we pivoting to a very different topic, and this is deaths from gonorrhea. So this headline was, a woman in her 50s from Anchorage, Alaska, died from a rare but severe complication of untreated gonorrhea. According to a bulletin from the Alaska Department of Health, the woman arrived at a local emergency room with respiratory distress and was diagnosed with septic shock and heart failure. Further testing revealed that the infection had spread throughout her entire body. Chad, this one, I know anything is possible, but what makes this infection, particularly this case, such a rare and dangerous complication of gonorrhea? It just seems so unusual.
Yeah, Joe, it really is. But to ensure listeners understand the full picture, so gonorrhea is caused by a bacteria called Neisseria gonorrhea. You might have heard of Neisseria meningitis, which causes all sorts of neuro issues and things like that. But Neisseria gonorrhea is usually sexually transmitted, and it poses some problems that make it really unfortunate for those who get it. So it's really twofold. First, it's typically asymptomatic in women. So what that does is cause a delay not only in diagnosis, but ultimately treatment. And then secondly, the bacteria itself has developed resistance to many antibiotics over time, which makes it harder to treat. So in this case, this woman could have been asymptomatic, not known it. And then by the time that she did start having symptoms and sought treatment, it had already become worse. If left untreated, gonorrhea could cause, specifically for women, pelvic inflammatory disease. It can cause issues in men, and most severely, disseminated gonococcal infection, or DGI, which is what most likely happened with this unfortunate woman. When you progress to that level of infection, it gets in the bloodstream and can cause all sorts of issues, from joint pain, liver inflammation. It could cause heart valve damage, brain damage, and unfortunately, ultimately death, as was the case in this woman.
Chad, is this just an isolated, very sad, tragic story, or does this happen more than we know or gets reported? Except, when it makes it across all these headlines because it's such an unusual story.
It is unusual, to be clear, deaths due to gonorrhea, at least in the United States, are extremely rare. Usually, most people will have symptoms, which means they will get diagnosed and then get treated, even in women, before they progress to severe complications. The CDC reports about 600,000 cases of gonorrhea every year, with a mortality rate somewhere around 8 deaths per 100,000 cases. But it could be even rarer than that. That data really is aggregated over a long time. So I do think these deaths are rare, but unfortunately, they can happen in the right circumstances.
Chad, what does this tell us, if anything, about sexually transmitted diseases? We have talked about this issue many times with you on this show, but what does this kind of reveal a new insight or give us some other piece of information in general, other than just a very sad, unusual case?
Well, I do think this is a very sad, unfortunate case. I do think that it can tell us a few things. Gaps in prevention are being held consistent, if not worsening, in many parts of the country. When we talk about taking away public health funding, or closing health departments, or slimming down federal agencies surrounding health, these could be some of the unfortunate consequences that happen because we're not educating, we're not providing that support free of cost or as a local community effort. I mentioned earlier about vaccines, and I think it takes money and people to run effective prevention programs when it comes to vaccination or otherwise. And so when we see these funding cuts, we can unfortunately expect this. I also think it shows the dangers of antibiotic resistance, which gonorrhea certainly can become. I've spoken on previous shows about that topic and how we have made some progress on new antibiotics, but it's slow. And again, as I had said before on a previous episode, it's not always well funded by the pharmaceutical companies. So I think this whole case and more, and when we talk the larger picture of vaccine preventable diseases, I think it continues to show us the importance of education, of public health funding and messaging to combat health misinformation. But I think this is a theme that really crosses all sorts of diseases right now.
We're going to pivot to yet another topic. And to anyone who's listening out there, I know they would agree with this. It is hot outside. And as a result, hydration really has become a big issue. As global temperatures rise, many people are turning to hydration multipliers. These are powders and tablets added to water to stay hydrated. Now, experts stress that plain water is still the gold standard, but these products can help in specific situations like prolonged exercise or outdoor activity by replenishing electrolytes lost through sweat. However, caution is also advised. So, what should we know about this? Dr. Arden, I'm going to point this at you. I can tell you personally, I remember I asked for some water when I was traveling recently, and they gave me water and they gave me a powder with it. I was like a little shocked because that was like, well, okay. So I guess my question is, are hydration multipliers necessary for the average person, or is this a marketing thing more than medicine?
Yeah, the quick answer is really no. These are not necessary for the average person in their day-to-day lives. What these hydration multipliers or enhancers or supplements are marketed to do is to essentially make your hydration more effective in a way. They contain additional sugars or glucose and electrolytes like magnesium, potassium, and sodium. But really, unless your diet is really deficient overall and you're just not drinking enough regular water routinely, these products are just not necessary. And I would argue with my patients in a nice way, or really just recommend that if this is a concern, to really then focus on those healthier practices, right? Let's have a better, well-balanced, overall healthy diet. Let's make sure we're hydrating with plain water. Let's make sure we're taking care of ourselves, getting enough sleep, those sorts of things to make us feel healthy. Plain water truly is the best for hydration. And if there are ways for patients to help maybe consume better quantities of water if needed, that can be safe and healthy too, like flavoring with some fruit. So we can work with that with patients if needed. But again, the quick answer is no, this is not something for most of our patients to need to think about on a routine basis.
To those folks who are out there, Dr. Arden, who, they swear by them, what are the risks of overusing electrolyte powders? Especially if you do have high blood pressure, hypertension, or kidney disease, are there real risks, or is it pretty gentle in terms of safe to take these things?
Absolutely, there are risks. And I think sometimes there's the perception that if something is natural or if it's a supplement, that means it's safer. My patients know this about me. I always ask them to tell me if they're going to consider taking something new over the counter or introduce a supplement, particularly if you're on a number of medications or have other health conditions, because they can have significant risks. A lot of times this involves really looking at the label of the product, right? Label awareness is something I think most of us could probably do better with. So looking to see what is included in that product. So, how much sodium, how much potassium, are there extra ingredients that are being sneaked in there that we don't need or that could be unsafe for that patient? So for example, as we've talked about, these products often have extra sodium, and that's marketed for that reason, to kind of help with, maybe sodium loss with sweating and those sorts of things. But this could lead to a condition called hypernatremia or excess sodium, and that can be pretty detrimental. It can have pretty significant symptoms for a patient, including diarrhea and vomiting and dizziness. And in some cases, patients even need to be admitted to the hospital for us to treat those symptoms and correct their sodium. Similarly, magnesium and potassium especially can also cause significant physical symptoms as well, and complications including muscle weakness and even heart arrhythmias that can be dangerous and even sometimes fatal. So these are not benign products. When it comes to patients with other chronic diseases such as diabetes, I'd be careful about the sugar content in those products. And then the same word of caution goes to patients with kidney disease and hypertension. Sometimes those extra electrolytes can actually be harmful for them as well.
Dr. Arden, for those folks who just wonder whether they should just be taking an electrolyte supplement with their water, how can people know if plain water just isn't enough? The people who swear by the Gatorades, the Propels, or any of the other powdered sugars and other supplements. Is there a situation where you really should be, or it's not a bad idea to try this, to play the other side?
Yeah, I would probably think about two specific situations that I would consider that, either for myself or as a patient. One is that kind of advanced athlete, that endurance athlete who's going to anticipate being outside for a long period of time, sweating for a long period of time. There's probably a good role to think about that in that situation. Perhaps for routine exercise, again, not necessary if we can just hydrate appropriately. I might also consider this with some maybe guidance from your physician if you have other health concerns in the setting of fluid loss, maybe with, say, like a stomach bug or a gastroenteritis, where we're trying to hydrate and replace some of those electrolytes. But other than those types of situations, again, for most people out there, just really focus on that overall healthy diet and making sure we're drinking enough regular water. A good rule of thumb to know you're probably well hydrated is that aside from your first morning urine, if your urine is otherwise clear to light yellow, you're probably hydrating pretty well. And if you're super thirsty, that probably means you're behind the ball. So think about, in those cases, just staying ahead of your thirst. And then lastly, be careful about things like caffeine and alcohol, which can, they're diuretics. So we would need to catch up with hydration in those situations too.
Up next, our experts answer your questions. And we'll be right back.
Did I get a letter? Did I get a postcard? Woo! Mr. Postman.
Welcome back. I'm Dr. Joe Sirven, and this is What's Health Got to Do with It. Our producer, Stacey Bennett, joins us now with questions for our experts from our listeners. And Stacey, how are you?
Hey, I'm doing good. How are you?
I am doing good. I'm excited to go through these questions. What do you have for us?
Well, they're interesting.
Okay, let's go.
This first one is from Kia from Flagstaff. She says, apparently we're making headlines for something I did not see coming. A case of the pneumonic plague in Arizona. Should the rest of us be worried, or is this more of a don't pet the prairie dogs kind of situation? And seriously, how is the Black Death still a thing in 2025?
Wow, Stacey, I'm going to point this at Chad as our infection control person. First of all, let me point out, I don't think it's a good idea to pet any prairie dog. It would be my first thing I would tell Kia at this point.
When in doubt, keep your hands to yourself.
Right, exactly.
Yeah. Keep them inside your car and locked in your cabin. So Joe and Kia, yes is the short answer. Plague is still a thing, and arguably it has never not been a thing. Plague is one of the oldest bacterial infections known to man. It's called Yersinia pestis, and it's most often transmitted by the bite of fleas or the inhalation of infectious rodent droppings, right? So it's not necessarily the rats that caused the Black Death. It was the fleas riding on the rats that caused the Black Death that bit people. So although I think most listeners shouldn't be too worried, plague is typically found. It is endemic across much of the Southwest United States, clustering around sort of Colorado, Arizona, New Mexico. And it's mostly in areas where rodents thrive, so abandoned houses, abandoned properties, where you have fleas. And so I think the key here is if you maintain your property well, make sure you rid it of rodents and fleas and ticks and bugs, and don't pet prairie dogs. You should be able to avoid the disease just fine.
That's a good lesson for all of us. Stacey, what else do we have?
Mary Ellen from Jacksonville, Florida says, I'm seeing all these headlines about the boom in DO schools, and I have to ask, what's the deal? What exactly is a DO, and how are they different from an MD? Is this just alphabet soup, or does it matter who's treating me? Should I pay attention when I pick a doctor, or is a doctor just a doctor?
Dr. Postis, I'm going to point this one at you. I think this is a terrific question because the fact is there are a lot of DOs, MDs, now nurse practitioners and physician assistants, all with initials and lettering after their name. And maybe patients and listeners are confused. Why don't you help Mary Ellen with what this all means?
So I'm going to start with a joke, right? What do you call the doctor that did the worst in his or her class, was the laziest, scored the lowest on their tests, and showed up to the least amount of class?
Okay.
A doctor.
Doctor.
Yeah, listen, Stacey got it right.
Right. So just like we can have people who go to MD schools and not do super well and still pass, you have to pass and be called doctor, similar to DO schools. I've had some colleagues who I know in various different medical subspecialties who are absolutely brilliant. I'm talking the sharpest mind in the hospital type of people in all sorts of different specialties. I think the big thing there ends up being folks who are certified with their national certifying bodies in various things, with whether it be neurology, neurosurgery, rheumatology, infectious disease, internal medicine, et cetera, the list goes on. Those are the standards that we hold dear to make sure that somebody understands what they're doing and how best to help their patients. So I think in terms of an MD-DO, if you look for that certification, we all end up taking similar types of tests that make sure that the standards are high across the specialty. I think the bigger question of service to the patient is this someone that after you see them, are they listening to you? Or are you able to have a level of comfort and discussion with them that you feel like your point is or concern is being put across? So that's a different type of question. So I'm answering a question with a question, but I think the certification standards should stand alone to justify DO versus MD. Looking for that certification will be very helpful.
So at the end of the day, a doctor is still a doctor.
That's the long story short.
Right?
Yes.
I love it. Stacey, what else do we have?
This comes from Sylvia from California. She says, so I keep hearing about microplastics. They're in our food, water, air, even my morning coffee. Recent studies say they may cause some serious health issues down the road. My question is, How on earth do I get rid of these things in my environment? Should I start wearing a hazmat suit to the grocery store? Or is there a more practical way to avoid being a human Tupperware container?
Oh, I'm laughing at the sense of humor here, Dr. Arden. Why don't you help us here? I appreciate Sylvia's sense of humor and her question. But what do you tell people, since these are headlines that happen so many times lately? I mean, how exactly do you get around not being around plastic in your food?
Yeah, you're right. This is a topic that has been getting a ton of attention recently. And for better or for worse, it's going to be essentially impossible for us to avoid plastics entirely, as they do really make up, most of our day-to-day lives and the things that we do. So we're just simply put, we are surrounded by plastics in every environment that we live in. It's in the air we breathe, it's in the food we eat, it's in the products that we wear and use day to day. We can find plastics in most containers and packing material, and it's used to make clothing, bedding, towels. So again, things that we're using day to day. They're used on a larger level for construction and motor vehicles, tires, and then even in healthcare, we use plastics
Yeah.
for many of our products and environments too. So my answer to Sylvia is it's probably, again, not going to be possible for you to avoid entirely, but I think there's two ways for us to think about this. One is kind of personally in our day-to-day life, what are some ways that we can reduce our exposures? So using a refillable water bottle that's made out of steel or glass is a helpful way to avoid plastic water bottles. Same with other kinds of containers. Using stainless steel or glass products for food storage is important as well. Recycling when we can. I think we can all make a better effort to do that. Those are the day-to-day things that we can do. And then, of course, on a larger level, we're just going to have to get more engaged systematically for good policy changes to help protect our environment, legislation that can help us have access to different resources to avoid this. But I think this is a good starting point just in terms of day-to-day practices that you can start as early as now.
Love it. Stacy, what else do we have?
Ben in Denver says, I just got back from vacation and I've got a question that's been bugging me. My hotel replaced all those cute little bottles of shampoo and soap with big refillable ones. Am I the only one who thinks that's unhygienic and a little gross? How do I know the last guest didn't turn that thing into a science experiment? Should I pack my own toiletries from now on, or am I just being dramatic?
Chad, let me first start by agreeing with Ben. I hate those. I know I'm supposed to be more environmentally conscious, but I'm with him. I like my little personal little bottles, knowing that I'm the first one opening that. Talk about that for us, because this has been bothering me too.
Yeah, so it's a really interesting question, right? And actually, I just stayed at a hotel this past weekend that had the multi-use bottles in the shower, but they had locks on them, so you couldn't take the lid off. And that was the first time I'd ever seen that. So this is difficult, right? There's not a lot of evidence of contamination or deliberate tampering and that it occurs at such a high rate. But I won't lie to you, theoretically, there could be risks there. There could be contamination with whatever. It could be simple things like diluting the product so it doesn't do what it's supposed to do. But by staying in a hotel, right, you put your trust in that hotel to do all the things to keep you healthy, whether that be cleaning your room correctly, maintaining the products and the soaps, refilling your coffee and making sure that it's not poisoned, right? And spotting all these other issues. But as you can imagine, it's probably not always 100%. So could there be a risk? Maybe. But the good thing is that travel size bottles are relatively cheap and probably better products for you anyways versus what the hotel provides.
Fair enough. We have time for one more question. Stacy, what do we have?
Devin, a neurology resident in Albuquerque, says, so let me get this straight. We're now at a point where my earbuds might know more about my stress levels than my own therapist. I'm all for better sleep and focus, but who exactly is reading my brain waves, and why do they get to share them with third parties? Should I be worried that my neural data is becoming the next hot commodity, or am I just being a paranoid prefrontal cortex?
I love this sense of humor. Dr. Posas, I want you to speak to Devin to make him feel a little better, but he also has an interesting question as well.
So I don't know that I'm going to make him feel better, because if this is a paranoid prefrontal cortex question, I may need to put on my little tinfoil hat, because here's the thing. we know as a society how good tech companies are about ethical practices. And the short answer is not very. So, do I imagine a future dystopia much like the oldie but goodie movie Minority Report,
Yeah.
where we each get our own retinally sponsored billboards in our eyes as we're walking around? That's a nightmare. But yeah, I think step one towards that dystopian future is unrestricted access to our own personalized data. So, I'm sitting here wearing a watch that tells me my heart rate and a ring that tells me my oxygen percentage as I'm sitting here. We need stronger regulation. I don't know that self-policing is going to work, but I think we need to ask for our politicians and our policymakers to sort of put some oomph into personal data protection and privacy. So Devin in Albuquerque, if this is something you're passionate about, this may be a good advocacy point for you, because we probably need to think about this before it just, becomes privatized advertisements here.
We'll let that serve as our final word. I want to thank our incredible group of experts that have helped sort through all of these questions and topics today. Thank you, Dr. Tina Arden. She's a practicing family physician at Mayo Clinic in Jacksonville. Thank you, Chad Nielsen, who is Director of Infection Prevention and Control and Epidemiologist at Nemours in Orlando. And Dr. Jose Posas. He's a practicing neurologist at the University of Virginia in Charlottesville, Virginia. Well, that's our program for today. We hope you've enjoyed our show. If you missed anything, you can listen to the full episode at wjct.org and on your favorite podcast app. Thanks to all of our guests. Our executive producer is David Lutkin. Stacey Bennett is our producer. Brady Quorum is our director. Caden Collins is our researcher. If you have any questions about this or any topic, let us know by calling us at 904-358-6362, email us at health@wjct.org, or tag me on social media at jsirven. I'm Dr. Joe Sirven, and you're listening to What's Health Got to Do With It on WJCT News 89.9 Jacksonville. Thank you for listening, and stay in touch.
Support for What's Health Got to Do With It is provided in part by the American Brain Foundation invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at AmericanBrainFoundation.org.
Rethreaded needs you to make a difference in the lives of human trafficking survivors. Learn more about supportive services and an array of survivor-made products at rethreaded.com.
And by Neurelis, a leading neuroscience company focused on the development and commercialization of therapeutics for the treatment of epilepsy and other neurologic disorders. The company's unique drug portfolios strive to address unmet needs in patient care. Learn more at Neurelis.com.